continue with congenital diseases. Okay. So cardiovascular malformations are anomalies that occur in the heart of the blood vessels. They occur relatively frequently. Oh, I'm so sorry. I forgot all about those. Can someone push those buttons that's over there? I'm sorry. They occur with some frequency in domestic animals. They account for about 10% of all heart disease. The other types of heart disease are things that happen after birth, like microvalvular insufficiency. Most are compatible with intrauterine life. And if the defect is mild, you may never know until like at necropsy or something. It can be an incidental finding. Intermediate defects are those that result in clinical signs later in life, and then you can have extreme defects where they die early in life or in utero. So cardiovascular anomalies can be due to many things. It can be due to some genetic defect, different chemicals or drugs consumed by the mother, different toxins, nutritional deficiencies, radiation. So I always, if you think you're pregnant, wear your lead apron, and other physical anomalies. So, I mean, things happen. So we're going to talk about the species frequencies in which you see these congenital malformations. So in dogs, the most common thing you're probably going to see is going to be a PDA, or patent ductus arteriosus. Do y'all know what that is, or what the normal counterpart of that is in utero?
Yeah,
So it connects what two vessels?
aorta and the pulmonary artery.
The aorta and the pulmonary artery. So in utero you need that, but after birth it should close up, right? So because you want your blood to go into your lungs. Huh? Were you saying something?
Is it the ligament arteriosus?
Mm-hmm. Yep, so after birth and once it closes, it's called the ligamentum arteriosum or arteriosus. But if that remains patent, you get a patent ductus arteriosus. You get persistent right aortic arch, pulmonic stenosis, and subaortic stenosis. Those are your most common in the dog, and we're going to talk about each of those. In the cat, they more commonly get endocardial cushion defects. And I think I have, yeah. So just in the endocardial cushion, without going into a long explanation, embryologically, it's what is responsible for your valves and the atrial septum and the proximal part of the ventral septum. So you have like this little structure in the middle, and you know, it causes all of this to connect right here in the middle. So when you say endocardial cushion defect, you're talking about a defect in this area right here. Okay, so this was an example of a severe endocardial cushion defect where you had a complete defect or complete loss of formation. So you had an atrioventricular valve abnormality and an atrioseptal defect and a ventricular septal defect. Yes.
Is that something that they can actually live with?
No.
Okay. Making sure.
I mean, you may be born with it, but you're going to have too much mixing of deoxygenated blood to survive. And that's severe, and it comes in various forms. Like you can have just the atrioseptal defect distally is an example, but your valves can be intact. That's one of those you can kind of patch up. Okay. You have atrioventricular valvular dysplasias or malformations of the valve and septal defects. In the cow, atrioseptal defects, ventricular septal defects. Transposition of the great vessels is something you most commonly see in cattle, and valvular hematomas. And valvular hematomas, also known as valvular hematosis, are congenital incidental findings. So you see it a lot in young bovine, but with age they go away and they don't cause any problems. In pigs, they commonly get endocardial cushion defects, and subaortic stenosis. And in horses, you don't really see many congenital defects of the heart. Okay, so now we're going to talk about those things. So I tried to bold, I probably should have changed the font or something, like the important breeds to remember associated with a congenital defect, because I'm gonna talk about common, but you're not gonna remember all of those. But the ones that it's very prominent in, you need to remember. So poodles get PDAs. It's very common because it's an inherited trait in poodles. Okay? You also see it in, you can see it in any breed, but other common breeds are collies, Pomeranians, and Chihuahuas. There's a greater, yes ma'am.
You say poodle, you mean, is there a size preference?
Usually the small ones. Yeah. I didn't even think to put that in there, but yes. There's a greater incidence in females. And we already talked about it's an abnormal connection between the aorta and the pulmonary artery. And normally there's functional closure a few hours after birth, and then the ligament forms about 7 days after birth. So just before we talk about like the signs you see, so here's an example of a patent ductus arteriosus. So normally this is how it should look. You have so here's your pulmonary artery, so this is your right ventricle, and this is your left ventricle where your apex is. And your pulmonary artery comes out of your right ventricle. Your aorta is like behind it and comes underneath and out of your left ventricle. So normally, in utero, the blood from the left ventricle, you don't want it to go, the blood from the right ventricle, you don't want it to go into the lungs, so it goes directly into your aorta. Okay, so that's what that's for, and that's where it is. Okay. And clinically, what you'll hear is a continuous machinery murmur. That's going to be the classic clinical sign that you'll read. Continuous machinery murmur. Large patencies can result in heart failure, right or left side. And initially, the blood is going, because the pressure in the aorta is greater than the pressure in the pulmonary artery after, once you're born, the blood is going to be going from the aorta to the pulmonary artery into the lungs, right? And that's okay. I mean, it's not good because you're kind of diminishing the amount going to the body, but it's still oxygenated blood going back into the lungs and kind of being recirculated through the left side. But eventually what's going to happen is your right side now has to compensate for this extra blood coming into the pulmonary artery. Okay, so it has to pump harder because you have excess volume in the lung. And then you have more blood coming into the lungs than it should, so you can get pulmonary hypertension. And that's going to cause the right side of the heart to eventually have greater pressure than the left side of the heart. Everybody following that? So when that happens, you can get a reversal of flow. So then you have a right to left shunt, which means now on the right side of the heart, you're going to have deoxygenated blood going into the aorta. And that's when you start to get the cyanosis and the exercise intolerance, and that becomes incompatible with life if it's not corrected. And that reversal of blood flow is called Eisenmenger complex, which I think I have it here somewhere. So we'll talk about that. But once that happens, and which usually will happen, especially if it's a larger patency, over time, these are some of the clinical signs you'll see: cyanosis, fatigue, lack of stamina, dyspnea, hind leg weakness, and blood loss. Okay. So this is just another example of the same thing. So with the PDA, the blood is going out into the aorta, it's shunting into the pulmonary artery, and what we just said. And over time, the pressure here becomes excessive, and then it starts to shunt this way. Is everybody clear on that? This was an example of a PDA. Here's your aorta, your pulmonary artery, and this big dilated connection between the two. And I just noticed this knife. This knife is like propping it up so you can see it, but it's right there. Okay, any questions about PDAs? All right, so persistent right aortic arch. So the pathogenesis is that normally, and just think about the aortas on the left. So normally the left aortic arch persists, but in this case the right aortic arch persists, which is where the problems happen. And this is all embryologically when your heart and great vessels are forming, and you have two arches that are there, and one of them like goes away, degenerates, involutes, and it's a normal embryological process. But normally, the right one goes away and the left one persists. So what happens is, and I'll show you, I think I can show you more than tell you. Okay. So this is normal. So normally, this one, the left, so, and just imagine like this animal's like this. So this looks like it's on your right, but it's on your left because he's laying down or the dog's laying down, so the right arm is to your left, okay? So normally, this one persists and this one goes away, okay? And so then this branch here becomes your brachiocephalic trunk, and you have your right carotid artery and right subclavian artery. All right, and that goes away, everything is great. So here is your right here is your esophagus dorsally, and your trachea ventrally, and your ligamentum arteriosus that comes here, which is between your aorta and your pulmonary artery. All right, and here it is here. So you have your left aortic arch, what's left of the right aortic arch, which is your brachiocephalic trunk that comes off of your aorta, your trachea, esophagus, trachea, ligamentum arteriosum, and right down here is your base of the heart, because this is your pulmonary artery, your right pulmonary artery going that way, and your left pulmonary artery going that way. So everybody sees those components, because those are the components when your right aortic arch persists that causes the problem. So we see the base of the heart, right? The aorta, the ligamentum arteriosum. Everybody sees that? Okay. And the pulmonary artery. Okay. So when this right arch persists, instead of the left, which was on this side, this is what you have. So what it's causing is your esophagus and trachea to be encircled and entrapped, which is what results in the clinical signs we're going to talk about. So in this case, here's your right aortic arch, and everything's still coming where it's supposed to be coming from. Your left side of the heart is here. This little cusp right here is your aortic valve, okay, your pulmonary artery. But the problem is because it's not on this side, and it's on this side, it's entrapping your esophagus and trachea, okay? So you have your pulmonary artery, your base of the heart, which is down here, your ligamentum arteriosum, and your right aortic arch, or your aorta. So that's what entraps your esophagus and trachea. And now we'll go back and talk about it, okay? So what happens is your trachea and esophagus gets displaced to the left, like we showed, and it becomes encircled by, just visualize what we just saw, or go back to it while I talk about it, your aortic arch, your pulmonary artery, the base of the heart, and the ligamentum arteriosus. So if this is the problem, what do you think you need to do to fix it? Surgery. What do you cut? Yeah. So it's an easy fix. That's the good thing. Cut this, and now it allows this to be able to move to the left like it needs to and not be entrapped. Okay? So the clinical signs you see, I should ask you. What are the clinical signs you think you'll see?
Dyspnea, inability to eat.
So you say dyspnea. So do you think it's going to be constricting the trachea?
Vomiting.
Vomiting. Okay.
Wouldn't it be regurgitation?
Regurgitation.
Oh, regurgitation. Right.
I'm just listening. I'm going to tell you. Some are right, some are wrong.
Oh.
What else?
Lethargy,
Okay. Why do you think lethargy?
because you're not getting any energy from the food.
Okay.
Coughing?
All right. So very good. So just looking at this, you can imagine what the clinical signs are. So actually, the trachea really is not affected. And why is that?
Cartilage.
The cartilage rings keeps it from being constricted. So the problems really result from the constriction of the esophagus, which is just
Rubbery.
muscle. So what you get is regurgitation. So once they start, you see the signs once they start eating solid foods, because the food can't go down because this area is narrow. You don't see it when they're drinking milk. That's really not a problem. So this becomes constricted, and if this becomes constricted, what do you think happens proximally to it? Megaesophagus. So those are your main clinical signs. Megaesophagus, dysphagia, or difficulty eating, and regurgitation. Okay, not so much dyspnea. And yes, because you're not eating enough, you definitely can have poor weight growth and lethargy, all that stuff. All right, so dysphagia. I don't know why I don't have megaesophagus there, but I should. So megaesophagus is like what you'll see on a radiograph, which causes dysphagia, and megaesophagus is dilation of the esophagus. Regurgitation of solid food, which can cause aspiration pneumonia, so that can be a sequela, and malnutrition. So that's in bold. This is hereditary and German Shepherds. And other predisposed breeds are Irish Setters and Boston Terriers. Have y'all seen the little table chair that dogs can get in and open up and sit in, and they got
Bailey's chair.
Bailey's chair. Is that not the coolest thing?
So cute.
Yeah, and so myasthenia gravis causes megaesophagus. But this you need to correct. That you can't correct. What tumor? Yes. Yes, ma'am.
How much would it cost to correct something like that?
I'm not sure.
Oh,
Looking at Dr. Big, I think Dr. Big has done those surgeries.
how do they go about, like, do you have to break the thoracic?
You can cut through the intercostal muscle and you use that retractor to access the heart.
Okay.
Yes, you don't have to break the sternum.
Okay.
So in junior surgery, y'all probably have opportunities to do stuff like that. And if not, give yourself the opportunity. Like on days when it's terminal day, that's your opportunity to get the most out of that, the procedure. So they'll let you do it. At least when I was a student. I don't know how things are now, but when I was a student, we really tried to take advantage of those opportunities to get as much surgical experience as possible. I'm going to write that down though to look up how much open heart surgery. I'm not sure. So everybody heard the tumor that results in the paraneoplastic syndrome with myasthenia gravis?
Yes, thymoma.
Thymoma. Are we good on this? This was just another example showing the same where you have it normally. So imagine the head is facing this way and the tail is facing this way. So the left side of the body is facing you and the right side of the body is on the other side of your laptop. So this is how it's supposed to look, where the aorta, ligaments arteriosus is on the left and your esophagus and trachea is on the right. And an example of persistent right aortic arch, where the aorta is on the right, and so this comes across the left side and encircles. I need to explain that, or are we good? So atrial septal defect. We only have about 8 more minutes. We probably won't finish, but we might. So breeds with the greatest frequency: boxers, Doberman pinschers, Samoyed. There is no hereditary predisposition that I found. There are 3 types of atrial septal defects. This is from closest to the AV valve to farthest away. Okay. So the ostium primum is in the lower intraatrial septum. It's not commonly observed. That's if it was part of the endocardial cushion defect. That's where you would see the hole. Ostium secundum is another name for patent foramen or valley. That's the one you're going to hear about all the time because that's the most common. and is situated in the mid to upper intraatrial septum. This is actually another one of those embryologically relevant, what is the word I'm looking for? I don't want to say hole, there's another word, but septal connection. Huh? Foramen, yeah, that's the word. So that's normally there, and then it closes near the time of birth. And sinus venosus is when it's higher up in the intraatrial septum. That one's also not common. Okay. This is gross, totally, but this is a patent foramen ovale, and someone with their raw hands got their finger through.
Is that you?
No,
Why do they have gloves on?
no, this is the question we all would like to know. And this is a very, very, very old picture. These are like man hands. But yes, there was a student in my class who would, she would do the rectal exams bare handed. Like what? So, like, under your nail.
I don't want to shake that.
I would not eat from her dish at a time. Okay, so similarly with any shunt or foramen between right and left heart, initially the blood flows from the left to right. With large defects, it can go from right to left.